Hey, this is Jeremy, and today we're going to be talking about the cardiac conduction cycle. So the big thing with cardiac conduction cycle is this is how blood gets circulated throughout our entire body. If it was not for this process, then we would not have any circulation. So to get us started, we have what's in front of us is going to be a circle, and that's just going to be the outline of our heart. Now your heart's made up of 4 different chambers, and they're all connected in their own little way. So what you have is we're always going to be operating off of our patient's right and our patient's left. So this top left segment of this circle is going to be the right atrium. This top right one is going to be the left atrium. And then you have your right ventricle and your left ventricle. All right. And so with that being the case, that's going to be the foundation of where we start. We know that the right atrium has blood flow to the right ventricle, the left atrium has blood flow to the left ventricle. Now, to start, we have our SA node. Our SA node is going to be what actually kicks off this entire process. And so with your SA node, it is going to be your primary pacemaker. And with it being your primary pacemaker, it pretty much sets the tone that your heart is going to follow as far as what the pace of your heart rate is going to be. Now your SA node is also going to be represented on an EKG if we had a isoelectric line. That's pretty much whenever we're looking at an EKG, it's the flat line. Now your SA node, what it does is it triggers the contraction of your atria, and so because it has these accessory pathways, and these are also going to be your internodal pathways. And now, so with these internodal pathways, what they do is they cause your atria to contract. They essentially have your right atrium, your left atrium, and they allow it to contract and push blood into your right ventricle. This entire process right here is going to be represented by the P wave on the EKG. Now the P wave is a very, very small little bump at the very beginning of the cardiac cycle. And then you have your internodal pathways, and that's actually what's causing the atria to contract. Now, your next thing that we have is we have something called the AV node. Okay, and your AV node, it stands for the atrioventricular node. Okay, it is the secondary pacemaker. And its main purpose is going to be to slow down the conduction. So it slows the conduction. Now, if you think about this, your heart is it's about the size of your fist, and if you have electricity that is flowing from one side, the top side of your fist, to the bottom side of your fist, it's going to be very quick because electricity does have a very, very fast rate of travel. Now, part of your AV node, though, what it does is whenever your atria contract, it actually causes a pause. And with that pause, it allows your ventricles, your right ventricle and your left ventricle, it allows them to be able to fill. And whenever your right ventricle and your left ventricle fill, then they're able, whenever they contract, they're going to be able to send out blood. If we had, if we did not have the AV node and it did not intrinsically slow the cardiac conduction, what would happen was your heart muscle would essentially squeeze at the exact same time, and we would not really have any blood flow because we wouldn't have any fluid inside of our right ventricle or left ventricle to be able to pump out. Now your AV node is going to be represented on your EKG by something called the PR interval, or the PRI. Okay, and your SA node is going to be called your P wave. Now your PRI, your PR interval, this is the pause. Your P wave is signifying your atria contracting, and your PR interval, there's where no electricity is happening. And we'll be talking about that in a later video. But that is the purpose of your AV node. Next thing we have is we're going to get into our ventricles. Now, whenever we get into our ventricles, we have this thing called the bundle of His. Now, the bundle of His, what happens is this is coming down the septum of your ventricles, so your ventricular septum, and then it's going to branch off into your right and your left bundle branches. And so these right here are going to be your bundle branches. And if you've ever heard of anybody saying that they have a bundle branch block, what is occurring is there is a block in something right here in this area. Now, your bundle branches, and so are really just a continuation of your Purkinje fibers. And so your Purkinje fibers is something that is causing your ventricles to actually contract. Now you have a couple different Purkinje fibers, and a good thing about this system that we have through the cardiac conduction system is your SA node. It is just a cluster of Purkinje fibers that are operating on their own program. The AV node is a cluster of Purkinje fibers that are operating on their own program. And as we get further down the line, the bundle branch, which is just a cluster of Purkinje fibers, and as we get further down, all these are just Purkinje fibers, and they're just kind of spread out and allowing the heart to do a little bit more work. Now, your Purkinje fibers, they have the ability to act as a pacemaker, but they typically do not. And this is going to be due to the fact that they're not very effective. Okay, and so these are going to be your Purkinje. Now, what I mean by your Purkinje fibers not being effective is whenever your Purkinje fibers actually contract, they're only contracting right here in your left ventricles. They don't really send the stimulus back up very effectively. That is going to cause your atria to contract very well. So they're relying on passive feeling. So every time your ventricles contract, they're hoping that their blood's just going to kind of pull into them, and then it's going to be able to squeeze and contract and push that blood out again. Now, with your SA node and your AV node, we have our atria contracting, and we have our the pause, which is allowing our ventricles to fill. Now, whenever we get into our bundle branch and our Purkinje fibers, we're actually hitting something on the EKG, and this is going to be represented by your QRS complex. And so with your QRS complex, if I can draw it a little bit narrower, this right here is going to be your this is ventricular contraction, and we'll be talking about that a little bit more. And then another thing that we have is for your atria to contract, it has to relax at some point. So your atria contract. So we have, if we draw another heart and we divide it up into top and bottom, what happens is whenever we have our P wave causes contraction of the atria. And then you have your AV node, which essentially causes the stop. And then you have your QRS complex. And your QRS complex, that is going to be your ventricles contracting, and that's going to be sending blood out. And again, that is going to be represented by your QRS complex whenever we're looking at the EKG. Now, for everything that contracts, it's going to have to relax. Now, your P wave or your atria, they actually relax in the middle of your QRS complex after your ventricles have already sent the blood out. And your ventricles, they're going to relax next, and they're going to relax through something called the T wave. Now, the T wave is just a little bit bigger bump, and the reason that's a little bit bigger is because there's just so much tissue. And so what we wind up with is a PQRS T complexes. So whenever we mention the P wave, we're referencing atria contraction. Whenever we reference the QRS complex, we're really going to be referencing ventricular contraction. And whenever we reference the T wave, we're going to be talking about ventricular relaxation. All right, so to kind of give us a better idea as to what we're looking at, we're going to draw this on out again. And so we have our P wave. This is going to be atria contraction. And we're going to have our PRI. And this is going to be the pause. And with it being the pause, this is allowing your ventricles to actually be able to fill up with blood. And then we're going to have our QRS complex. And it's very narrow typically. And this right here is going to be your ventricular contraction. And it is also going to be your atria relaxation. And whenever your atria relax, it's allowing them to be able to be filled via your pulmonary vein and your vena cava. So your QRS, ventricular contraction, and atrial relaxation. Now this next step, this next thing, this very large complex right here, this is going to be your T wave, and this is represented by ventricular relaxation. And this is allowing your ventricles to actually be able to fill up or get ready for that next stage of being able to accept an electrical stimulus. This gets a little complicated, but as long as you understand that your P wave is going to be represented by your atrial contracting, and you have your QRS complex, which is going to be represented by your it's going to represent your ventricles contracting. That's really going to be the big thing, because whenever we're interpreting an EKG, the biggest concern that we have for rhythm interpretation is going to be, what is the relationship between the atria and the ventricles? And us looking at the EKG is just a way for us to be able to tell that. And this is going to be your cardiac conduction system.